Hello, everyone. My name is Dr. Avery Everhart, and I'm a distinguished fellow here at the Center for Applied Transgender Studies. And it's my great honor to welcome you all to this first event in the center's Distinguished Lecture Series for 2024. So, events in this series feature world-leading transgender scholars discussing their own original research with a broad audience of scholars, practitioners, policymakers, and interested public. And at the end of today's event, I'll be announcing the next speaker in the series, so make sure to stay until the very end. Unless, of course, you have to go, we'll forgive you. So now, with that sort of little cough introduction out of the way, let's get to today's speaker. So Stef Shuster, PhD, is an associate professor in the Lyman Briggs College and the Department of Sociology at Michigan State University. They earned their PhD in sociology from University of Iowa, and with a certificate in gender studies, and their bachelor's is in sociology from Indiana University, Bloomington. Their research focuses on how evidence is a social artifact that is constituted through social, cultural, and historical context, with a particular focus on how medical providers negotiate evidence to make medical decisions within uncertain terrains, such as in the case of transgender health, which we'll hear lots about today. And so they'll be delivering a talk about their recent book, which I had the pleasure of reading multiple times and writing a review for. So I'm really excited to hear it live, loud, and in color, called Trans Medicine, the Emergence and Practice of Treating Gender. Dr. Shuster is going to speak for about 40 to 45 minutes, at the end of which we'll have as much time as we have left before the hour for some moderated Q&A. So during the talk, do feel free to use the Q&A function in Zoom to submit your questions. And with that, I will turn it over to Dr. Shuster.
All right, great, thank you. I'm gonna just take a second to pull up a PowerPoint. All right, great, thank you. Well, thank you everyone for being present today. I'm gonna go ahead and get us started and set up the case by bringing us into a scene from an observation from a healthcare conference that I observed. So a young medical doctor tentatively raises her hand in a darkened auditorium that holds 300 of her peers and asks the panelists at a transgender healthcare conference how they make decisions about enabling or blocking access to hormones for their trans patients. The young doctor continues to reflect upon how she struggles the most with patients who are non-binary identified, meaning their gender identities are neither woman nor man, but somewhere outside or beyond these categories. One panelist who's worked in trans medicine for over 20 years chuckles, leans into the microphone, and explains that it's sort of like spidey sense, you know? You have to feel it out. The audience nervously laughs while nodding their heads in agreement that when handling uncertainty in medical decision-making with trans people, one must trust their gut instinct or so-called spidey sense. So sitting in the audience, I was taken aback at this exchange. All of the training that medical providers receive in internships, in their residency programs, and in the years beyond medical school advances their knowledge and confidence about offering the best medical treatment possible. They look to publish research when they're presented with ambiguous cases. They call each other on the phone or knock on their colleagues' doors when they're unsure how to diagnose or treat patients. And to maintain their licenses to practice medicine, they're also expected to continue their education through regularly attending conferences. So all of these activities help providers develop a gut instinct about making medical decisions when managing uncertainty. In medical emergencies, relying on gut instinct can help providers quickly make decisions which can become life or death matters for their patients. But when confronted with uncertainty in medical decisions that are not quite so immediate, what factors are at play in developing and using gut instinct? Social science research consistently shows us that there are multiple mechanisms that exist that enable refusing or allowing trans interventions by providers. What's less understood is how informal and subjective evidence becomes crystallized, established, and perpetuated as providers accumulate knowledge and experience in gender-affirming interventions. So my book, Trans Medicine, begins as an acknowledgement that providers of trans medicine have an established authority over gender and asks, how has medical authority over gender happened? I trace what has become normal and legitimate through decades of practice in trans medicine to consider the consequences of these trends, not only for trans medicine, but the medical establishment more broadly. Trans medicine is an effort to find opportunities for a more inclusive and just healthcare system. So the research questions that guide my talk today, and I'm kind of doing a little bit of blending between chapters 4 and 5. First of all, are what are some of the contexts that shape uncertainty in trans medicine? How do providers of trans medicine manage challenges to their expertise? And what are some of those consequences in medical decision-making and also working with their trans patients? I'll tell you a little bit about the data just so you have a sense of what I'm drawing from before we get into the results. So I began this project before I even knew it was going to be a project. I arrived in Iowa City in 2007. I had already identified as queer, non-binary, and trans for some time. And like a lot of folks moving to a new place, I asked around to find out what providers were knowledgeable about trans-affirming care. And I was kind of struck by these blank stares from colleagues and also friends in the trans community in Iowa City. So I began meeting with providers, working with trans communities to organize workshops, and helping providers become updated on how to work in affirming ways with trans and non-binary clients. So as a result of like this multi-year health advocacy work, I gained insight into the kinds of dilemmas in trans medicine that providers felt unequipped to navigate. But I also was facing the prospect that I needed to begin my dissertation work, which was animated through a lot of those years of trans health advocacy. So I spent 2 years in, I guess, 2 summers in the Kinsey Institute archives, looking at a lot of the correspondence between healthcare providers in the 1950s to the 1980s, which sets the stage for part 1 of the book on the historical contexts, where some of the uncertainties began to develop and the ambiguities and treatment protocols that providers faced. And in part 2, I focus more on contemporary realities. So I went out and I conducted in-depth interviews with physicians and therapists, and then also observed trans healthcare conferences so I could get an appreciation for how healthcare providers teach each other about working in trans medicine. It became clear to me that when trans people show up in their clinics, what providers describe experiencing is almost like an existential crisis. They're rarely trained in offering gender-affirming interventions. Trans healthcare is mentioned, and I think this is changing, which we can talk about in the Q&A. But trans healthcare is mentioned, if at all, typically on the one diversity day that occurs during a medical student's education. So this lack of training combined with most providers not having a lot of hands-on experience or opportunities to establish a body of medical knowledge to draw upon in trans medicine, it just raises a lot of uncertainty for them. What this means in my work, and I'll do the briefest background ever, what this means is that my work interfaces with the scholarship on expertise and uncertainty, drawing on some of the classics. Professional occupations are defined by expertise. So in healthcare, what that means is that we kind of have this expectation that providers know what they're doing and they make informed decisions in caring for their patients. Many providers called on to assist with working with trans people describe lacking direct clinical experience. So on a professional level, this lack of clinical experience and scientific evidence directly conflicts with those expectations that we have for providers as experts, and it puts them in an uneasy position when they work with trans people. So all of this uncertainty creates dissonance for providers because it conflicts with professional norms. And in the scholarship, folks have also talked about how when you have an abundance of uncertainty, it begins to call into question or cast doubt on a professional's claim to expertise, and many will go to great efforts to control it. So in trans medicine, a central reason why providers experience so much uncertainty, both historically and currently, is that they feel like they have very little evidence to draw from. In medicine, and this is like just kind of the last of the offering background information, in medicine, evidence takes a lot of forms. It can include data from research-driven activities such as clinical trials on the effects of hormones. It can also include clinical guidelines, diagnostic categories, to help offer guidance to providers in recognizing symptoms and recommended steps for treatment plans. And evidence can also be culled from clinical experience and learning on the job. So, and also as the opening scene made clear, gut instinct sometimes functions as evidence too. The mere fact, though, that providers richly describe concerns about a lack of evidence signals something sociologically important about the context that shape providers who make this claim. Sorry. So what I'll do is I'll just kind of take us through some of the common sources of uncertainty that providers gave voice to. And then I'll shift to presenting some of the findings on how they manage challenges to their expertise because of all of this uncertainty. So let's take Matthew, a physician who works in family care. He said, uh, uh, yeah, there we go. If I'm treating someone with lung cancer, there are clinical studies where the N equals 3,000 people or 6,000 people started on a new antibiotic. For most of the studies in trans medicine, we saw for trans women and treated them. It's bothersome and makes a lot of providers uncomfortable. So I want to be clear because this comes up a lot, that there is evidence in trans medicine. There's studies published on, for example, the efficacy of surgical techniques, or the effects of hormones on trans people's bodies, their mental health. But the physicians I spoke with acknowledged that these studies were helpful in understanding physical or mental health outcomes, and helped them to assess how much testosterone to prescribe. But these kinds of published results did very little to help providers address how and when to initiate, continue, or block access to hormones, or even just how to interact with patients in the clinic. So Jill, a family care physician, emphatically stated, I don't like the idea of feeling like I'm holding a prescription pad as ransom, but I am a licensed provider. I do have to work within certain confines to continue to maintain a practice. Amy, a gynecologist, echoed this idea, but focused on the challenges that she experienced assessing risks or benefits. So she said, it's always a balance of risks and benefits. I think as long as it's done in the context of the patient, where the patient is the center of the discussion and a part of that discussion. But there are places where I will draw lines when the risks are too high. But in my own sentence, asking someone who is truly trans to spend their life in a body that feels completely wrong is just horrible. It comes off feeling cruel. So providers are empathetic to the troubling aspect of blocking access to interventions. Some, like Amy, narrated these conflicting ideas about setting up boundaries for patients and refusing to offer gender-affirming care. What I also want to highlight in this quote is the use of the qualifier truly, because it comes up throughout the interviews. But when providers use a qualifier like truly in relation to a trans person, I think it reveals a crucial point of tension between trans people and health providers. So in a medical arena that involves working within an identity, who has the authority and expertise to decide if and when a person who claims a trans identity is truly trans is highly contentious. And that process that providers have tried to go through to verify um, whether or not someone is so-called truly trans for an identity that has an endless number of permutations creates turmoil for both trans people and also health providers. What providers are describing then when they say that they lack evidence and they feel uncertain is that from their perspective, they do not think that they have the adequate tools to decide under what conditions it might be acceptable to initiate or gatekeep gender-affirming care. Shannon, a physician's assistant, shared, when I'm working with a trans patient, I feel much more like we need to follow all the steps. If I have a patient that's not super compliant, it's like I quickly get into a zone of, you're making it tough for me to help you. We've got to follow the guidelines. You know what I mean? It's a real challenge. So as Shannon talked through the challenges of being asked to serve more or less as a gatekeeper, She recognized that the clinical guidelines that exist for trans medicine help to provide a structure for her to make decisions within. She also acknowledged that when patients ask for workarounds to the guidelines, her first impulse is to cast her clients as non-compliant, which later in the interview she expressed a lot of discomfort around. What I found interviewing providers is that some may unintentionally be engaging in trans exceptionalism, where they perceive their trans patients as so unique and so different from their cisgender patients that they have a really difficult time importing evidence and their experience from other areas of medicine into their decision-making in interactions with trans patients. But in addition to murky evidence, what else is driving these uncertainties? So in trans medicine, gender has been routed through both therapeutic and physician communities. These pathways to care are rooted in mid-20th understandings of who should treat trans people, and I use a lot of air quotes in this talk, and in what kind of disordered object is implied with treatment. In part one of the book, I examine the development of this field of medicine beginning in the middle of the 20th century. There were few trans patients during this time, and even fewer providers who worked in this medical arena. Providers faced accusations from those in the broader medical profession that they were so-called quacks. So to establish their credibility, they instituted a set of criteria for sorting through so-called worthy patients that mandated, among all, like a lot of things, normative gender expression. During this time, providers placed an extraordinary emphasis on normalizing trans people's bodies and experiences, and those patients whose gender closely aligned with traditional ideology were more readily granted access to hormone therapy and surgical interventions. Around the 1960s, physicians realized that they needed therapists to help them assess whether a patient seeking gender-affirming care was trans or if they were delusional. So at this time in the mid-20th century, being trans was understood as possibly a form of delusional thinking and or a symptom of schizophrenia. And there were just these intense legitimacy wars that erupted between physicians and psychiatrists, and between psychologists, because each of them were seeking to establish themselves as the leading authorities in trans medicine. They eventually began to work together to create agreed upon protocols, which we now might understand as clinical guidelines, and it increased their legitimacy by presenting as a united front. So if we skip ahead by the end of the 1970s, physicians and therapists began to work together in a team approach, but there still were lingering questions that in the second part of the book, I begin disentangling. And that is, it sounds like a simple question, but it is the goal of treatment to bring the mind into alignment with the body or to change one's body to bring relief to one's mental health state? And I'm sure that we can certainly appreciate that in this political context, this is a question that's kind of framing a lot of political discourse. So rather than taking a position, providers have tended to operate from the tacit assumption that the best way forward in medical decision-making is to understand trans identification as both a mental health issue, which places trans people under the jurisdiction of therapists, and to work from a biomedical model of care, which puts trans people under the jurisdiction of physicians and surgeons. And this has created a double whammy effect of medicalization in trans people's lives as they're subject to medical authority and surveillance from therapists and physicians. Despite the medical community's ambivalence about all of these things, evidence and their medical authority, how they begin to negotiate challenges to their expertise gives us an important insight into the fraught nature of claiming an expert status when the evidence and clinical experience continues to be unsettled. So what I'm going to do now is I'm going to kind of take us through two primary ways that providers tend to describe managing their uncertain expertise. And I'll start with the first one, and then we'll get into the second one. So there were some providers who were open about their lack of expertise, and I refer to them as uncertain experts. These were providers who comfortably leaned into the uncertainty that is pervasive in trans medicine. They were flexible in their interpretations of clinical guidelines and protocols, And they acknowledge that new medical fields, or from their perception, new medical fields, are difficult because there might be a lack of scientific evidence, clinical experience, and medical training. Uncertain experts were also open to sharing that they were anything but experts. So they described challenges along the way in reconciling that tension that they faced in being called upon as experts while having little evidence and sometimes very little clinical experience to draw from in trans medicine. So sometimes uncertain experts would manage their uncertainty by invoking humility. Take Eli Coleman, who is the past president of what is often called the World Professional Association for Transgender Health, or WPATH. It's the opening remarks of the morning plenary at the 2013 National Transgender Health Summit. And Eli Coleman is speaking with enthusiasm about, at that time, the latest standard of care that were crafted through a working group of leading experts in the field of trans medicine. So he's weaving this story in front of an audience of about 100, 150 people. And he's talking about WPATH as moving from an organization that used to explicitly pathologize individuals to one where patient-centered care was at the heart of the organization's philosophy, and how evidence-based medicine formed the structure of these new standards. But there's a quiet moment in his opening remarks, and he pauses and kind of off the cuff looks out into the audience and says, "We have to humbly acknowledge that we don't have a scrap of evidence that shows therapy is critical. While this was stated in previous versions, it is now clearly stated that psychological counseling is not a requirement to access medical interventions. We still maintain, when deemed necessary, a referral to a specialized health professional is recommended." For people who maybe don't have the context, what he's referring to is older versions of standards of care or those clinical guidelines used to mandate therapy. And in the new version, the 2013 version, they try to highlight that that was not like a requirement. No one in the audience seemed to react to this admission from Eli Coleman. They nodded their heads in agreement. And what struck me about this particular moment in the conference is that on one hand, psychologists have been asked to evaluate trans people's readiness for medical interventions. And on the other, Coleman's suggesting that there's no evidence that therapy was crucial in assessing how or why it was ever recommended in the first place. But I also want to note from this quote that Coleman also has a little bit of a contradictory logic by saying, "when deemed necessary." These words are another crucial point in understanding the tension in trans medicine and deciding under what conditions it might be necessary to refer a trans person to a therapist. So invoking humility leaves as an open question under what circumstances a therapist is necessary. I go into more detail in the book about gut instinct, which I can't stop thinking about, but I just want to highlight here that uncertain experts also describe using gut instinct. So Janet, a primary care provider, reflected, providers don't like not knowing things. To have something within the spectrum of my specialty that I don't know about makes me uncomfortable. Trans medicine definitely falls in that category, and I just sort of have to go with my gut and do what I think is best for the patient. Amelia, a gynecologist, described the first step in trying to redefine expertise, especially given her training, and started recognizing some of the broader structural problems in the amount of evidence and uncertainty that permeates trans medicine. So she reflected, "I would say the biggest challenge for me is the lack of knowledge and experience. And some of that's reflective of the field itself, as trans medicine is based on a lot of theory and conjecture." I want to highlight that Amelia has been working as a gynecologist for over 15 years and had an incredible wealth of knowledge and experience about how hormones affect the body. After all, as she explained, quote, "I work with estrogen all day long." But she noted a major difference between working with cisgender women and trans people's bodies is that from her perspective in trans medicine, it asked for her to extrapolate her knowledge from one area and type of body and try and apply it elsewhere. So uncertain experts offer a glimpse into alternate ways that providers can maintain their expert status, but also engage in creative workarounds to professional expectations. Many admitted that there was a problem with the lack of scientific evidence and clinical experience. They also made sure to acknowledge that trans patients, binary or non-binary, were not like the source of a problem. Instead, they became critical of those who presented with an expert front. So not all is well in is not all is well in trans medicine. There was a separate group of providers, those I refer to as self-assured experts, who tended to assume that decision-making is objective and standardized. And what I show is that many of these providers use the language of scientific evidence to gloss over their lack of expertise and to deflect attention away from the taken for granted assumptions that shape their work. In response to the uncertainty they experienced in trans medicine, self-assured experts tended to shift it onto trans people, who then were expected to convince providers that they were certain about gender-affirming interventions. And this is also the place in the presentation where I want to share that some of the quotes that I'm about to present are difficult to hear and also quite insulting. So self-assured experts leveraged interpretations of scientific evidence, but presumed or presented them to be facts to bolster their claims to expert status. During a grand round session on new research in trans medicine organized on behalf of a local hospital, the presenter, who's an endocrinologist, looked out into the crowd of both new and seasoned medical providers and began his presentation by asking, "What is the easiest way to change someone's gender?" And his response was castration. The audience erupted in laughter. So I think the point he's trying to make is that removing an individual's gonads would help that person's body absorb the hormones that were introduced through hormone therapy. But this endocrinologist is also insinuating that one's bodily configuration determines one's gender. In further detailing the goal of treatment, the endocrinologist continued to explain that for females to males, the goal is to stop the menses. That's going to be the single most important thing that you do. They no longer will have a sense of belonging to another gender. The message seems to be here that, at least for trans men, you inject a little testosterone, you add in a swagger while walking, you top it off with a hint of musk, some increased muscle mass, and voila, you have a man. But these kinds of ideas about gender that are understood through a medical perspective and supported by stereotypes become packaged as scientific fact. This way of presenting information to each other, I also show, leaves little room for ambiguity in clinical practice and meaning making of what role medicine has to offer in working with people and their socially constituted gender identities. So Evan, a family care physician, said, when I get a patient who does not have a clear, solid gender identity or goal of changing, I get concerned about what is my role. I'm the medical person. I'm not the therapist. I'm not the social worker. I'm not the support groups. I'm not the social service people. So those are the folks, and he's talking about non-binary people. Those are the folks where I don't know that medical physical transition or stopping of current gender presentation is the right way to go. I'm not exactly sure that medication is the right next step for them. So as Evan suggests, for those trans people or non-binary people who seek medical interventions, it's up to them to assure providers that they are like so-called truly trans. In the process, trans people are mandated to be good, normative, worthy patients who can clearly articulate why they're seeking medical interventions to avoid some of this gatekeeping. But these practices are not without consequence, as trans people seek medical interventions are always under the surveillance of providers who hold more power in health encounters. And then I'll offer one last example quote before I start wrapping this up. Self-assured experts also tended to assert their medical authority to uphold their claims to expert status. In response to the uncertainty they experienced in trans medicine, again, they shifted it onto trans people who then had to convince providers that they were certain. So Sam, a nurse practitioner, emphatically stated, and this is a long quote, sorry. I ask my non-binary clients who are seeking medical interventions, what are we trying to do and what is the goal? If it truly is someone who wants to, for the rest of their life, maintain an androgynous appearance, I can't do that. Living in an androgynous place in the world is great, but difficult. And anyone who's really transitioning will tell you that that's not their purpose. And that year starting hormones is hard, socially, for employment, and for family. So I want to talk to non-binary folks for quite some time about why they would want to stay there in an ambiguous gender presentation. I usually let them for 3 years. There's no evidence to suggest why 3 years, that's just my feeling. But after that, they need to go back to the therapist, talk about what they really want, and make a decision. There's a lot happening in this quote, and I think we probably could spend the whole hour just unpacking this. But what I want to draw your attention to is that questioning a non-binary person's intentions for fitting into a normalized trajectory for physical transition not only helped self-assured experts temper their uncertainty, it also helped them to accumulate authority and mandate conformity to binary gender expression. As medical providers reroute the expectation of certainty onto trans patients, many patients are at risk for denial of access to care. So just to summarize, I talked through 2 common strategies that providers use to to respond to challenges to their expertise, given the vast uncertainty. In response to all of this uncertainty, there were some providers who doubled down on their authority, insisting that they're the providers and patients should follow their orders. This group of providers hold a principled view that medical authority helps to create order in a decision-making process that, from their perspective, feels disorder. And of course, these are the self-assured experts. But there were other providers who were more flexible and described working, but sometimes stumbling, their way towards clarity and what a best practice might look like. They sought to find a middle ground between patients' needs and medical authority. And in the process, many of the uncertain experts find that they learn more about gender and the everyday lives of their patients who seek their help in gender transitions. Confronted with a lack of evidence to guide their decisions and often little experience with this population, providers face a considerable degree of uncertainty in medical decision-making. So here I examine how providers attempt to impress upon others that they're knowledgeable and competent to work with trans people. Many providers are uncomfortable with the possibility of not knowing what they're doing, but some experience even greater discomfort acknowledging it to their patients or to the public. The performance of expert becomes transformed into the reality of expertise. And as I show, there are some providers of trans medicine who have begun to believe the performance. This work also has some broader implications that I just want to talk through, and then I'm really excited and curious to think with you through your questions. So some of the broader implications of this work, first of all, is how evidence itself becomes weaponized. Medical evidence is a social artifact that's mobilized by providers to construct expertise, but can become weaponized when it's used against people in their embodied experiences with gender. Confronted with a lack of scientific evidence to guide their decisions, and often having very little experience with this population, providers faced a considerable degree of uncertainty in medical decision-making. So in teaching each other, especially at those healthcare conferences, providers framed themselves as experts to mitigate their uncertainty in working with trans people, and also to convey their authority and knowledge of trans identities and trans medicine. Medical providers in these settings, though, are veiled under the authority of medicine, which shifts the attention onto mandating the certainty of their trans patients in seeking medical care. One of my concerns is that for those patients who do not, cannot, or choose not to follow these normative narratives, and they seek alternate understandings of their relationships to gender, the medical community responds in kind by mandating conformity to normative gender identification. I also want to return to the example that introduced the talk, which was the Spidey sense moment. Here we learned that when trying to assess whether or not a patient is ready for medical interventions, a nationally recognized provider quipped that it's sort of like Spidey sense in how they make decisions about whether or not to allow patients to have access to care. As a consequence of these practices of managing expertise, providers shift their concerns onto trans people. And as a result, it oftentimes was non-binary people and non-normatively gendered trans people who became subject to the scrutiny of the medical field as they became named and then explained away as somehow inauthentic expressions of trans identification. And meanwhile, providers' authority is upheld and relieved of scrutiny from the broader medical community. Looking beneath the surface, we see that providers, like most humans, have a really difficult time reconciling explanations for their behaviors and may even unintentionally perpetuate health inequalities in their negotiations with trans patients. So when providers try to apply medical logics and sometimes pseudoscience to socially ascribed categories and identities, patient self-determination is undermined in clinical encounters and also in accessing healthcare. As such, the case of trans medicine involves a clash of epistemic ideas about pathology and one that has real effects on people's bodies. So in the process of conducting research for this book, what I learned is that in analyzing trans medicine, it's not only about studying, at least in my field, sometimes it's perceived as like this small offbeat area to study. But the findings from the book are really drawing attention to centralized dilemmas regarding the authority of medicine and science and how to work in medical areas that are defined by uncertainty. These are prevalent features of contemporary medicine in general, and I think we certainly saw it in 2020 as the COVID-19 pandemic was unfolding. My findings are also pointing to a vital need for all health providers to be properly trained in working with trans people, which would have spillover effects in more adequately meeting the needs of all their patients, learning to work within gender variance, and avoiding this perpetuation of health inequalities. I think there's a lot of questions that remain about what the future of trans medicine might look like and how medical uncertainty can be resolved in ways other than providers doubling down on their authority. Uncertain experts offer us a glimpse into a different way that providers can proceed through their uncertainty, even while they feel challenges to themselves as experts. But the findings presented over the arc of the book suggest that providers need to refine their thinking of trans people as a puzzle to solve or a problem to fix, and instead become more flexible in navigating professional norms and placing more trust in clients as the experts over their bodies and also over their identities. So I will stop there and say thank you. And I guess we'll shift into Q&A.
Amazing. Thank you so much for the talk and a brilliant pace too. We have lots of time for questions. Um, so I will avoid doing the selfish thing and keep my own questions for the end if there's time, because I do see that we have plenty in the Q&A. So do feel free to continue to use that function if you're an attendee that has a question. You can also upvote things. So there is at least two questions that I'd like to sort of combine. So if you want to open the Q&A on your screen to make sure that I'm also not missing any of the pieces, there's two that mention Harry Benjamin and sort of this, we could maybe even call it a proto-trans history from before the period that you were really looking at, I think, in the Kinsey archives. And so Madeline Stump asked about the term true in reference to patients' transness and queries how much of that comes from Harry Benjamin's construct of the true transsexual, beginning in his book, The Transsexual Phenomenon. And then Cam Cannon is asking a really similar question and started it with a thank you and said, that they were wondering if you could talk a little about the shift of a passing focused lens on green lighting care, again, in reference to Benjamin and also references Beans Veloci's work on Harry Benjamin. And this new current emphasis on true transness, which seems to be less about potential passing and more about a kind of diagnostic essence, is the word that Cam seems to be using, and wonders how this shift came about. And I'm fascinated to hear what you think.
Yeah, absolutely. I think these are both questions, and it makes sense that they're put together. So I'll focus on the first part first before shifting. So I think as far as like if we go back to the 1950s and 60s, and that is where I spend a lot of my historical context, and I think we can look to great authors to understand that that's not like the beginning of trans medicine, but that is like the beginning of a coalescence of a medical field that we now recognize as trans medicine. And when we look at the correspondence between medical providers and how they're trying to like sort through this growing patient population, it's Harry Benjamin who has a pretty significant um, like a pretty significant force in shaping even now like what we think of as standard practice in trans medicine. So what is a true trans person for Harry Benjamin? I think that wait, those questions went away. um, a true trans person. Oh, sorry. I'm getting used to the webinar format, so I can click on the answered tab. A true trans person for Harry Benjamin, like in that use of the language, it's not only coming from Benjamin, it's like it's through a growing, but it's like a small concentrated group of providers who are trying to find medical consensus. And they all land on that, you know, a so-called real trans person or a true trans person is someone who is gender normative, white, middle class to affluent, has you know, like stable employment in gender conforming ways. So you know, like for them, it was really a question of how do I know that the person before me is trans? Because at the time, like there was a lot of conjecture, especially from the therapeutic community, that being trans might actually be a symptom of delusional thinking or schizophrenia. And so that's also like why they brought therapists into the process in the first place was to for physicians to feel more comfortable in making these assessments. But I think that like the idea that there is a so-called true trans person also helps us understand why there's so much work going on from the 1950s until now for providers to sort through like so I'm looking at Cam's question. Cam's talking about like, you know, there's been this shift from like so-called passing to a diagnostic essence. But when I look at this history and I look at the discourse that providers are using in the 50s and 60s, the kinds of questions that they're asking about trans people and the challenges that they experience, it looks pretty similar to me in the interviews that I did with providers and observing them in healthcare conferences. And they might use slightly different language, but I think that symbolically, what providers are still grappling with really is, am I making a mistake that puts my license at risk? And like, how do I know? Because like, there's no diagnostic test. Like, you can't run a blood lab and be like, yes, this person's definitely trans. So I think that there's those lingering uncertainties and they want to get it right. And I think that what we see historically and even right now is that in trying to get it right, there's a lot of providers who get it horribly wrong. In trying to box trans people into a really restricted understanding from a medical lens. And I'm not convinced, and Cam, like maybe we can have a conversation later. I'm not convinced that like it's changed all that much. I think the language they use has changed. But I think some of the same underlining assumptions have traced through the last 75 years. So
Yeah. Thank you for that answer too. I'm gonna have to pull the transcript from this because I'm like, I want to. So I'm gonna pull the next question. This one comes from Taryn, possibly Taryn Gundling. Um, and says surely there are other groups of rare patient groups for whom there's limited training and data. And I think in the middle here is an especially strong open-ended question that I really like, but there's some other framing stuff. So
Yep.
do providers express the same discomfort or uncertainty with those other populations? And then asks, is there something deeper happening involving challenges to a foundational and perhaps unexamined basis for medical training that presumes there are specific treatments for females and males, regardless of gender identity and expression? And then more concretely, they're asking, is a trans man assigned female at birth, for example, treated using protocols for males rather than females or vice versa?
Um, yeah, so there's a lot in that question. I'll say first of all that throughout the book I am thinking from a comparative perspective of not only what is like the case of trans medicine teach us about like trans medicine, but how is it reflective of broader problems in the medical community. So if we look at how, for example, therapists described trans people in the 1960s and 70s, it's kind of invoking a pretty similar discourse to how cisgender women were medicalized by therapists through like the lens of hysteria, you know. So there's definitely like a lot of overlap happening, and I'm certainly not suggesting that I'm not suggesting necessarily that there's something unique to trans medicine. I think that where it can get really tricky for providers, though, does it goes back to the idea of like the diagnosis, and that in some ways, when providers are confronted with a trans person, whether it's their very first trans patient or whether they've worked with trans people for 15, 20 years, there's still this question that they have to ask themselves, and how do I know that this person is really a trans person? And there's not, like, and in thinking through that question, what it really does is it places power into trans people's hands to say, I'm a trans person. And I think there's a lot of medical professionals who find that incredibly discomforting because it also challenges their authority. And as far as like emergent medicine, we certainly see, if we think about the development of Lyme disease, for example, when patients first started showing up in clinics, and in Lyme disease is really hard because there's just so many symptoms, that doctors put it back on the patient, and they were like, like I don't know what's wrong with you, and maybe it's something that's happening in your head. So I think that like that leaning back onto that it must be a mental health explanation because physically I don't have the tools to detect what is wrong with you is like the first like impulse. And we see that happening with a lot of different areas of emergent medicine. Just as we see it in trans medicine, we can look to things like Lyme disease or COVID or like a lot of different emergent illnesses. I'm not suggesting that being trans is an illness, by the way. Um, but then they start to concentrate their knowledge, and that kind of creates a pathway moving forward. And what I find really compelling in trans medicine, and this gets back to the first question, is that it still strikes me that 75 years after like the small cluster of doctors, which eventually became more clinics opening and closing and now opening again, that there are providers who feel incredibly uncomfortable and ill-equipped to work with trans people. And that most of their training is coming through 1 or 2 days throughout their entire medical education. And that does create I think that is where trans medicine gets a bit unique, is that, like, think about all the knowledge we have around COVID and even how much knowledge we had within the first 6 months of COVID. I mean, there was certainly a lot of misinformation, but like that was 6 months and the medical community like had answers. But we're 75 years into the coalescence of trans medicine as a field, and there's still like these basic questions that providers have, such as the ones that are ending this question. Like, there's not necessarily medical consensus on if you're reading a cholesterol lab for a trans woman, should you use cis women or cis men or trans, like, should we gather more data I mean, I think we should gather more data for trans women, but like, what is the baseline for cholesterol levels for trans women or trans men? And it's like, these are unsettled questions. that also makes providers feel unsettled. So.
Yeah, I think there's quite a lot there. And briefly, I'll also say that that's one of the things I appreciate about the book. If you all haven't read it yet, you should get a copy and read it, or ask your library to get it, your local or your institutional library. So I think that's something that was especially striking to me that you did, was you were, instead of just saying, let's find what's strange about the familiar, a classical sociological exercise, you're like, actually, there are many ways that trans medicine is kind of an exception. And also, this is at least partly a function of contemporary medicine that I thought was it was very eye-opening for me. So I appreciate that extension through answering this question. We definitely have lots more, so I'm going to try to filter. And I'm going to go a little bit by votes, but also where I can combine things, I will. And I actually think that there's two here that I'd really like to hear together, because I think they might kind of relate, from Carly Burrell and Ina Bliss-Kadosh. So Carly first asked, what do you find is an effective way to move the needle when it comes to providers who fall into the self-assured expert category? And Ina's question, which I found to be related, is where do you think trans activists and the trans community can fit in promoting trans-related literacy in healthcare?
Yeah. So I look to the the folks who are uncertain, like I look to uncertain experts to get a little bit of hope. Because like there's so many different layers of inequality that are playing out, I think, in the lives of trans people when they interface with health. But it's the uncertain experts that I think have a lot of room to teach self-assured experts about how to like lean off of, especially like the like doubling down on the medical authority to resolve their own uncertainty. And like it's not like for uncertain experts, they just wake up one day and they're like, aha, I get how I've been doing it wrong, like all along. Like there's actually, they talk through it for them, it required them to really grapple with their own power in mandating certain things, like, you know, mandating steps that trans people would have to go through before they could access medicine, and feeling uncomfortable with that kind of power over people's lives. And then like some self-reflection of what do I need to feel like I can meet this patient where they are rather than where I think they should be. And so in that way, I think it like it, not to be, you know, I guess Pollyannish about this, but I think it does take some empathy for providers to say, this doesn't feel right to me. I don't want to do it this way anymore. So what does it take to do it differently? And then to get to the second part of that question about promoting, like what might trans people or trans activists do to help promote trans-related literacy or even competency in healthcare. I think that especially for the uncertain experts, it was the moment that they decided to relinquish their control and actually start listening to their patients and their patients' experiences over their own bodies and lives. And what they found is that not only do they learn more about trans people and how to work within more of an informed consent model rather than like the old doctor knows best model, but they actually found that they learn more about their patients and how to be better doctors in the process for all of their patients. Like, you know, learning how to stop making assumptions about people and asking questions, spending more time with patients. Like these are all things that uncertain experts talked about learning from their trans patients and then importing that into their work with their other patients as well. So I think that it's like, it's a multi-step process, but it seems to begin from a place of like relinquishing control over medical authority when it comes to gender. So.
Yeah, thank you for that. So we still have quite a few left. So I'll encourage anybody whose question we don't have time for to follow up by email. I believe Dr. Schuster shared their email address earlier. Um, yeah, so because we probably only have time for one more question, I'm going to be a little selfish and pick the one that I like the best. There are lots that are also comments, including some that are about the Standards of Care 8 revision that was pretty recent, thinking a lot about positionality of providers versus patients, but one that I like in particular is actually one of the most recent at the very bottom from Gray Babs. And this is pretty specific to your book. So how did you think about positionality of providers in the work? And potentially for trans and or non-binary providers, how does their lived experience relate to their professional expertise in your opinion?
Yeah, so when I was collecting, I guess the first thing I'll say is when I was collecting data, it was a moment, and I think that it's getting a little bit better, but not all that much better. There are not a lot of trans or non-binary medical providers. And I think that makes sense if we consider like the structural inequities in higher education for trans and non-binary people to make it into higher and higher levels of education and credentialing. I mean, there were some folks who were in the therapeutic community, but not like physicians. And I do believe that's changing now, but it's still like incremental. So I will say that some of the quotes that I shared from the self-assured experts were from some of the few trans identified providers. So like that last quote where the person was like, if you're a non-binary person, you need to make up your mind. And if you can't, I'll give you 3 years, but then you've got to go back to the therapist. That was from a trans medical provider. So I think it raises questions about like trans people also may have stereotypical and discriminatory beliefs about other trans people. I mean, we see infighting in the trans community already, and I don't think it would be relieved just because someone has a medical license. But that doesn't mean that I think that there shouldn't be more trans or non-binary folks in the medical community. I think that similar to the last question, I see it as like a two-part problem. First of all, we need more trans and non-binary providers, and also like gaps and openings and possibilities for trans activists to be heard by the medical community. I think that's like one, and that is something that came out of the latest version of the standards of care is that despite their best efforts, there's a lot of trans activists who are quite frankly pissed off about the new standards because they still get things wrong. And trans activists were already talking about, like, in this place, this needs to change, or in this place, this needs to change. And the medical community saying, like, sorry, we're going to do it this way instead. So now I'm starting to ramble a little bit because I know that we're so pressed for time, but when I think about the positionality of providers, what I will say is that it's not just about being trans or non-binary, it's also about years in the field. So for those providers who were right out of med school and just beginning to practice, or those who had been in the field for 15 plus years, they tended to be the self-assured experts. And I think that makes sense because when people first get out of school, there's all that uncertainty and like fake it till you make it. So they lean right onto the guidelines and like stepwise process, just as those who've been in the field for a while are like, I already know how to do this because I've been doing it forever. But it's like people in that sweet spot of like year 3 or 4 until year 14, they tended to be more of the uncertain experts. So they've been in the field for a while, they have clinical experience, but they're also flexible enough to like interpret guidelines and to bend the rules because they've seen enough trans patients to know that following things like guidelines, to the T might actually create more harm in trans people's lives. So I don't know. I have so much more to say about that, but I want to be mindful of I can stay here for a few more minutes if we want to do more questions, but I want to be mindful that folks are like, oh, it's 1 o'clock your time, 2 o'clock my time. So
Yeah, I mean, I appreciate the generous offer. I think we can take advantage since you're willing and maybe do another question. I'm sort of trying to search to see if there's another like maybe cluster. But maybe if you want to take a look and see if there's one that you're especially interested to answer or something that sparks your interest, I think that would be great. Because I'm sort of just picking based on what are the things that I'd like to hear you talk about. And there's also lots of thank yous in here in the Q&A. So
Mm.
um, we appreciate those. And I will say that in terms of getting a copy of their book, I imagine it's available anywhere books are sold. But maybe Dr. Schuster has a specific recommendation of places. I always say your local bookstore, independent bookstores in particular, but
Yeah. No, I agree. Yeah, I always like local bookstores and supporting folks, because it's becoming more and more difficult for them, as more folks are purchasing books online or from your library. It's always nice when libraries have trans and queer scholarship. So yeah. I don't know, Avery, I'm having a hard time like focusing on any question in particular, but I just want to echo an appreciation for everyone's questions and the opportunity to think through them. Um,
I think one that might be especially interesting to you because, again, so much of your data focused on the provider side, is there's a question here from Davina Barbie that asks, how do you think these types of expertise that you discuss, uncertain versus self-assured, impacts the emotional labor that trans people often do when navigating healthcare options, especially in the context of specifically gender-affirming care or trans medicine?
yeah, and like before I started this project, I went out and I interviewed a lot of trans and non-binary people about their experiences in health and everyday life. But when I was a graduate student, I just didn't know how to tell the story of that data, so it is completely out of the book. But I certainly know from my perspective as both a researcher and also a trans and non-binary person that as I was listening to the ways that self-assured experts described their work with trans people and the concerns they had, um, and like when I'm interviewing someone, it doesn't matter how I personally feel. Like I always want the people that I'm interviewing to feel heard and respected. But I think personally, I was like, I'm very glad that this person is not my doctor. Because I don't know if I would be able to handle like, like you must do X, Y, and Z before I will allow you to do A, B, and C. Like that just it doesn't work in my world. And I think like there's a lot of trans folks who like it is that kind of invocation of medical authority that helps us understand, for example, the durable finding that trans and non-binary people are much more likely to delay care or avoid care altogether. Because when you have enough instances of doctors telling you what you must do, it breeds resentment and mistrust in that person. But I also think like, and I don't want to give a pass completely to the uncertain experts because a lot of them learned how to be better doctors based on the labor of trans people helping to teach them how to be better doctors and how to stop making assumptions about them, and how to be more flexible. So, I think there's also something there that helps us understand another durable finding in the scholarship, which is that trans people do expend a lot of emotional labor in healthcare. And part of that is because they're often put into the teacher role when they want to be patients who have health needs that need to be addressed. So, yeah. Yeah, so thank you for that question.
Yeah, thank you. We're now at the point where I am starting to have to go, unfortunately. And there are still lots of remaining things, so I would encourage folks to follow up. And there is a particularly interesting question that's got lots of upvotes. Um, about the standards of care, but more broadly about a theory regarding the pharmacodynamics of, I imagine, pharmacodynamics of exogenous hormones, the ones you would take as a medicine, as opposed to the endogenous ones, which aren't going to really, they're going to have different dynamics. And I think it's a question that in part might be a little out of scope by talking very specifically about the science of sex. But I did want to acknowledge it because it got lots of upvotes. And I think it's definitely something worth discussing. Otherwise, there's still plenty of thank yous and some other like shared things. I want to figure out if there's a way to like archive the Q&A or something, but I'm not exactly sure how to do it, hoping it will save all of this information. I haven't run a webinar in quite a while. But I do want to say thank you again to Dr. Schuster for making time. And thanks so much to everybody for being here. Please be sure to join us for the next event in our Distinguished Lectures series. The event will be held on Friday, February 23rd at the same time frame as this, 12 p.m. to 1 p.m. Central. And we're going to hear from Zain Marib, who will be discussing their new book, Terms of Exclusion, Rightful Citizenship Claims, and the Construction of LGBT Political Identity, which is out now from Oxford University Press. And if you'd like to register for that event, I will type it in here so everybody can access it. cats.events/Mrib. So thank you again to everybody for attending, and I'll hopefully see you all later this month. And let's give another digital round of applause to Dr. Schuster, and a thank you and expression of gratitude also for staying a little later to answer some extra questions.
Yeah, and thank you again, everyone who joined, and also Avery for moderating the session and helping with the questions and helping get this set up. So thank you.
Always happy to. Yeah, and we'll talk. I have loads of my own questions too. And thank you again. So take care, everybody.